Hi, everyone. My name is Tapan Kadia. I'm currently at the Department of Leukemia at MD Anderson Cancer Center in Houston. I'm going to be talking to you today about some novel strategies in the treatment of older patients with newly diagnosed AML. As you know, we've had significant advances recently with novel drugs and novel drug combinations in this subset of AML, which represents a pretty important need among patients, among physicians who treat these patients. We know that the majority of our patients who we see with newly diagnosed AML are over the age of 60, and so older, unfit is not an uncommon patient that we see. Moving on from our prior use of single-agent hypomethylating agents, the recent approval of the BCL2 inhibitor Venetoclax has dramatically improved response rates and has shown a survival benefit when combined with hypomethylating agents in the front line in patients who are older or otherwise unfit for intensive chemotherapy. And so in addition to that, we also have multiple new targeted therapies in patients who have FLT3 mutations, IDH mutations, where we're able to characterize the disease early on and assign appropriate therapy, typically on clinical trials where we combine target therapies with frontline lower intensity therapy. Now, for years now, we've been using hypomethylating agents as the de facto low intensity therapy, and there's been little innovation in that. And so we've been adding everything to the backbone of either Decitabine or Venetoclax. Can we take a bigger leap forward? Can we say that we can potentially develop a new, more effective backbone therapy in older patients or in unfit patients with newly diagnosed AML that potentially can lay the groundwork for new combinations in the future? And certainly, we've developed a strategy of double nucleoside analog therapy with Cladribine and low-dose Cytarabine, alternating with Decitabine, a program that we've been using now for many years. Recently published our long-term experience of 60-plus month follow-up, showing significant improvement in response rates compared to single-agent hypomethylating agents, and then also improved survival in that setting. We recently conducted a study and presented at the ASH meeting showing the combination of Cladribine, low-dose Cytarabine plus Venetoclax, demonstrating a response rate over 90% with a high rate of MRD negativity over 93% among patients who achieved a complete remission. So now we're achieving response rates that we were only seeing previously with intensive chemotherapy that we reserve for younger and fit patients, but we're seeing the same type of response rates and depth of response in older patients and even in patients who are unfit for intensive chemotherapy. Again, a non-anthracycline-based regimen, a new approach, a new backbone. The next steps that we're looking into is not only combining the Cladribine, low-dose Cytarabine backbone with Venetoclax, but also with other target therapies such as FLT3 inhibitors in patients who are FLT3 mutated, IDH inhibitors in that subset of patients, and maybe even in combination with gemtuzumab ozogamicin for many different types of patients, including those who have core binding factor, but may not be eligible for or be able to tolerate intensive chemotherapy that we see, that we usually reserve for younger and fit patients. So I think we're innovating in that way, trying to develop a new backbone, moving away from the single-agent hypomethylating agent strategy.